So today I have the privilege of discussing with you guys management of temporal lobe epilepsy. This is something that we very frequently encounter at our epilepsy center. And I'm going to sort of couch this talk into sort of several pieces here. First, I want to discuss just the basics of drug-resistant epilepsy. You may have gotten some of this in some of the other talks in this series, but I'll go through some of the basics of that. I'll sort of generally give you an overview of how we think about surgical treatment for epilepsy. I'll discuss a little bit about what a comprehensive epilepsy center is, what we do there, kind of how we strategize in treating our patients. And then lastly, I'll discuss some of the very specific surgical and or invasive therapeutic approaches we have towards epilepsy. So do we have the ability for questions here in this talk?
Yes, we do. There's a raise hand function, and also students can place their questions in the chat.
Okay, wonderful. So please feel free to ask questions anytime. And if you could just alert me to the question, that would be great. And hopefully we'll have some time at the end as well. So it may surprise you to know that in a recent survey that was conducted by the NIH, epilepsy is actually found to be the fourth most common neurological disorder in the US after things like migraine and strokes and Alzheimer's disease. There's a prevalence of 2.2 million cases with an incidence of about 150,000 new cases per year. So this is a real problem. So what is the definition of drug resistance? Because luckily, 70% of patients who are diagnosed with epilepsy do quite well with medications. However, a subset of these patients do meet this definition of drug resistance. And now this is a very clearly defined concept. It is the failure of two tolerated and appropriately chosen and administered anti-epileptic drugs, whether they're taken together or in sequential monotherapy. And an estimated 30 to 35% of patients with epilepsy have drug-resistant disease, meaning their seizures are not controlled with medication. It's really important to think about this definition because prior to about 2001, when this became clearly defined, really there was no kind of stopping point to what defined a patient as drug resistance. And now we have some really good studies that show us that if you failed two medications, your likelihood of achieving a seizure control with a third, fourth, fifth, sixth, 20th anti-epileptic medication really kind of go down exponentially. So we really want these patients to be identified so that they can then seek out further treatment, because a patient with epilepsy could actually go through a whole lifetime trying different anti-epileptic medications and actually never achieve control. So we want to prevent that. Why is it important, again, to identify these patients? Because there really are consequences of having drug-resistant epilepsy. Things like general disability, like unemployment, social isolation, the inability to drive, which can really be a major life factor depending on what city you live in specifically. And also there are side effects of persistent seizures and also side effects of the medication, the anti-epileptic drugs that we use in treating our patients. So things like mental slowing, reduced attentiveness, poor academic achievement, decreased memory, increased psychosocial problems, not to mention things like physical trauma from seizures. So it is really important to identify these patients. But, you know, from the perspective of psychosocial function, you know, quality of life is a really important factor when thinking about our patients and whom to treat. And we do know that it really makes a big difference, even when you compare patients who have at least one seizures per month, as you can see here in this plot, to those who have fewer than one per month or those who have none in the past year. You can really see that in this study that actually looked at 5,000 patients with epilepsy, really highlights that recurrent seizures can have a really significant effect on things like general standard of living, making plans for the future, the ability to engage in social life. And this really is a significant difference with those who are having frequent seizures compared to those who are not having seizures in the past year, who actually have similar numbers here to those of just your average controls. We don't really think about mortality in epilepsy, but it is something to consider. Patients who have untreated epilepsy do have a higher mortality than the general population. This is a study of 3,000 patients that were followed over 20 years and found that the standardized mortality ratio is around 2.1. And so it is something to consider. What is the cause of death for our patients with epilepsy? It is rare, but things like status epilepticus, accidents, suicide, treatment-related deaths, of course, even including surgical treatment. And then something called SUDEP, which is something I didn't know much about before entering this field. SUDEP stands for sudden unexplained death in epilepsy. And it's really described by the death of an otherwise healthy person who has epilepsy with no apparent cause. So these patients, are healthy, functioning in their normal daily lives, and will have a sudden, unexpected, and unexplained death. Oftentimes, they'll be found in their bed or be found in the shower or something that's very rare. The incidence is 1 in every 1,000 patients with epilepsy. However, it's much more common in those patients who are drug resistant than those patients who are controlled. So this is, again, something to think about. So really, it's a balancing act when we think about treating our patients with epilepsy. The goal here is to increase seizure control, decrease side effects, both from epilepsy and from anti-epileptic drugs. And the ultimate goal here is to improve quality of life. So the goals of surgery are to reduce or eliminate seizure activity while minimizing any potential complication from the surgery itself or a neurological consequence of the intervention. So now I'll talk about some of the surgeries that we use in epilepsy, and later in the talk, I'll delve into a little bit more detail about each one of them. I like to sort of categorize them as either palliative or definitive. The goal of a palliative procedure is to reduce the number or severity of seizures, whereas the goal of a definitive procedure is to cure the patient of epilepsy. We don't always meet that goal, but that is the goal if we embark on one of these treatments in this column. And nonetheless, when we don't meet that goal, we still more often than not attain a worthwhile reduction. The procedures here highlighted in red are those that are applicable to temporal lobe epilepsy, which we'll discuss today, and the ones in black are actually much less common and kind of outside of the scope of our talk today. So thinking about temporal lobe epilepsy, our major workhorse here is the temporal lobectomy, at least historically, and it is the most common surgical procedure we practice for temporal lobe epilepsy by far, and it's also the procedure we have the most rigorous data for. You can see here at the top of this chart that there are 2 randomized controlled trials when thinking about temporal lobectomy for temporal lobe epilepsy. Prior to these randomized controlled trials, sometimes people would think of temporal lobectomies and epilepsy surgery as something that didn't have a lot of good data driven behind it. But here, what we can see is of these in this 2001 study by Wiebe et al. 40 patients were included in the surgery arm and 40 patients were included in the control arm. And 58% of patients who underwent temporal lobectomy achieved seizure freedom, compared to 8% of patients who just received standard medical practice. So clearly it's a very significant difference. And of all patients in the surgical group, even though they didn't all achieve seizure freedom, 80% derived a substantial benefit from the procedure. When you look at our second RCT, Engel et al., smaller numbers, this was actually prematurely closed because of enrollment issues, but 73% of patients in the surgery group achieved seizure freedom after temporal lobectomy compared to none of the controls, and 100% of the patients achieved a worthwhile reduction in seizures. So those are the randomized controlled trials. If you look at just large meta-analyses, it really corroborates this kind of data that we have when it comes to looking at surgery arms versus the control arm. So what are the cognitive consequences of epilepsy surgery? Because that's what we most fear. Oftentimes we're doing resections of tissue. We spend a lot of time thinking about the viability of that tissue and whether or not a resection of this area of the brain will cause any sort of alteration in cognition. But if you look at the large kind of cohort of patients, when we analyze their neuropsychological data, we see that there are both gains and losses in patients. The vast majority of patients will probably not experience much of either, at least not notice it. But if we do very rigorous neuropsychological testing before and after, we do see, particularly when we intervene in the dominant hemisphere, in the dominant temporal lobe, we can see losses in verbal memory. That's really kind of the biggest, most feared complication. And now we have a lot of interesting options in the realm of neuromodulation, which are often not definitive, but palliative procedures, but allow us to circumvent this potential side effect. Also, similarly, in the dominant hemisphere, we can see decreases in naming, and usually in the non-dominant hemisphere, although in this study they really kind of looked equal, we can see some decreases in visual memory, although it's important to look at the other side where we also see gains in visual memory for those patients who have been treated. Things that don't tend to be affected are things like IQ and executive functioning. Again, we see gains and losses when we look at neuropsychological data before and after. And things like attention and verbal fluency actually tend to improve after a procedure like temporal lobectomy, really often ostensibly because we've now controlled the seizures, and usually can get patients after a period of time off of their anti-epileptic medications as well. Self-reported cognitive declines are rare in only 9% of patients, and cognitive gains are more common in 18% of patients. So it really is a balancing act, and it's important to understand, the dominance of the hemisphere that we're operating on. Nonetheless, despite the fact that epilepsy surgery can be extremely effective and can really provide a cure for a portion of patients, there still remains a lot of hindrances towards referral of epilepsy patients to epilepsy centers. A study was done about this, querying why, and it's really a lot of times, actually, unfortunately, a lack of awareness of clinical practice guidelines. These patients oftentimes will stay being treated by their general practitioner or a general neurologist, maybe never actually get referred to an epileptologist or an epilepsy center, and can really go a lifetime sometimes without achieving seizure control. So we want to avoid that. A lot of times referring practitioners are just not sure if a patient qualifies as having drug-resistant epilepsy, the definition of course, of which we discussed. Lack of knowledge or misconceptions regarding the safety and efficacy of surgery, concern for potential neurological complications, expensive surgery, which is of course covered by insurance just like any other surgery, Patients, of course, have their own specific hindrances, like just the concept of brain surgery, which is true for many of our procedures. Concern that the procedure is experimental. We see this in a lot of functional neurosurgery, including things like deep brain stimulation, which of course is not true. Lack of an understanding of the risk profile, or just never actually told that there was a surgery or a surgical option for their epilepsy. So this is really important to train both patients and doctors about what the options are and who qualifies to be referred to an epilepsy center. So now it's generally more accepted that the fulfillment of the definition of drug resistance in a patient should prompt a comprehensive review by an epilepsy center. If they meet the definition of drug resistance, meaning they've failed 2 medications, or if their seizures are not adequately controlled over a 12-month period. So when these patients come to an epilepsy center, what do we do and how do we think about this? Well, the goals of our surgical evaluation are, one, to identify the epileptogenic focus, determine the resection margins if that's possible, and of course evaluate the eloquence of involved and surrounding brain. But ultimately, epilepsy surgery is really detective work. These patients often come to us with normal MRIs and not a lot of clues as to where their seizures are actually coming from, and if they are coming from one location in their brain. So the goal really ultimately is to determine, is there a well-defined seizure focus, hopefully one, within this patient's brain? And if so, where is that focus? And is there an intervention that we can offer to help? So how do we do this big kind of detective project? We split it up into phases. So phase 1 consists of just a standard focused history and physical examination, a comprehensive neurological evaluation, critically, an inpatient audiovisual EEG. This is where the patient gets admitted to the hospital, to the epilepsy monitoring unit, and we place scalp electrodes on their head, and we usually have a video camera monitoring their activity. And oftentimes we'll keep them in the hospital from anywhere between 2 to 5 days for a study like this, so that they're in a controlled environment. And if necessary, the epileptologist may taper their anti-epileptics or do other provocative measures. And the goal of this study is for them to have a seizure in a controlled environment, so that we can see what they're physically doing when they have a seizure, which is their seizure semiology, which helps us in localizing where these seizures are coming from, and also see what their EEG activity is like through the scalp electrodes. That gives us a lot of detailed information about where seizures are coming from. We also do a very specialized MRI. We, on all patients, at least in our center, get a PET scan to look for a PET study's metabolism in the brain. And oftentimes a seizure focus will have actually decreased metabolism. That area will not be functioning normally, and we can often see that on PET. And we, on all patients, perform a comprehensive neuropsychological evaluation that can actually help us to also determine where the seizure focus is. For example, if a patient has a lot of naming or verbal memory dysfunction, that may localize their seizures to the dominant hemisphere mesial temporal lobe. That all of these things just provide us clues that we try to synthesize to create a plan. Phase 2, the numbers of these phases can be confusing. They're actually different in different parts of the country. Phase 2, I actually like to call phase 1.5. It's a more specialized and more invasive testing, and this is only testing we do if necessary. Ictal SPECT, I'll talk about in a little bit, functional MRI to lateralize language dominance and perform other things. A WADA test and MR spectroscopy can all be, as well as magnetoencephalogram can also be used as sort of additional measures to help us understand where seizures are coming from. Phase 3, which is also known as phase 2, is intracranial EEG evaluation, and phase 4 is a treatment plan, which may or may not be surgical. A patient might undergo this evaluation, and we might say, hey, we really don't have a good surgical option for you. So that's important when considering starting the workup. So again, phase 1, we discussed audiovisual EEG monitoring, assess the semiology. We do an epilepsy protocol MRI, a PET scan. You can see here on this PET scan, we're looking for hypometabolism. So this is a really nice picture where we see that the right side here has decreased uptake compared to the left side. And that can be a really nice clue as to where seizures are coming from. And then neuropsychological testing here in phase 1.5, sometimes known as phase 2. Ictal SPECT is done really at only in specific centers. SPECT, as you may know, is single photon emission CT. It utilizes a tracer to look at regional blood flow. And the way we do this test actually is to bring the patient into the hospital for the audiovisual EEG. And immediately at the moment that their seizure starts, we inject this tracer and then send the patient down for a scan. We take the ictal SPECT, subtract the intra-ictal SPECT, and then we can sometimes, if the study is done well, see the focus of activity where the seizure started. And I won't go into a lot of detail about these other tests, but happy to answer any questions about them. So just to recap, if a patient comes to us with drug-resistant epilepsy with a suspected focus, which is the majority of adult onset epilepsy, we go through this series of evaluations and then maybe also do specialized testing. So what do we do with all this information? Once we have all of this baseline information, next we discuss these patients in our epilepsy conference. This often includes a whole host of practitioners. So neurologists, our epileptologists, of course, neuroradiologists, neuropsychologists, and neurosurgeons, of course, are all included in this conference. And at that point, we decide whether or not we've figured it out. Do we have enough concordant localizing data to offer the patient a surgical treatment? So for example, if on inpatient scalp audiovisual EEG, we see activity in the right mesial temporal lobe, and the patient's semiology, meaning the way they're having seizures, what they're physically doing during their seizures, if that's concordant with right mesial temporal lobe epilepsy, and let's say on imaging, we see a PET scan with hypometabolism in the right mesial temporal lobe, and maybe neuropsychological evaluation may or may not help here. Let's say everything is concordant, everything really just looks like it's all coming from the right mesial temporal lobe, then we can say, okay, we think we know what's going on, and we might offer this patient a surgical intervention, which might be laser interstitial thermal therapy or a temporal lobectomy, and I'll discuss that a little bit later on. There's another sort of potential avenue here, which is that really we don't have any clue perhaps what's going on. We see activity everywhere, right, left, frontal, temporal, occipital. Seizures are coming from multiple parts of the brain. Maybe there is no focus, or maybe there are many, many regions of activity. And in this case, we might say, hey, we don't really suspect that there's a focus here, or really this is very widespread multifocal epilepsy that we don't think we'll be able to get a handle on as far as a surgical intervention. So that patient may not be a candidate ultimately for surgery after this initial workup. We might consider in these patients a palliative procedure, kind of that is more general, something like vagal nerve stimulation, for example. Now, the interesting sort of scenario occurs when we have indeterminate findings or non-concordant findings, meaning we have a good idea what's going on based on this initial detective investigative workup, but we're not confident enough to offer a surgical intervention. So for example, let's say we see on audio visual EEG that seizures are coming both from the right mesial temporal lobe, but we also see activity on the left. And we don't know, are seizures independently happening on the right and the left, or are seizures all starting from the right, but then rapidly spreading to other parts of the brain, including the left? So we're not entirely sure, and we have a hypothesis. Then we consider intracranial monitoring. That is a scenario where we say, we think we know what's going on. However, we need to test our hypothesis by essentially doing another audiovisual EEG, only this time, instead of the electrodes being on the surface of the skin with scalp EEG, we're actually going to surgically implant these electrodes into the regions of brain where we suspect seizures are happening, and then see if we can actually localize the seizure, test our hypothesis, and see, is it really the right and the left independently, or is it all the right just spreading to the left, for example? So how can we do intracranial EEG? There are various techniques that we use in intracranial EEG monitoring. We can perform a craniotomy and place these cortical grids and strips. We can implant these depth electrodes through a craniotomy. There are other things like foramen-ovale electrodes, which are less commonly used, and epidural peg electrodes, which are almost not ever used. And then there is sort of a newer option, by newer, I mean really the last decade, that now more and more epilepsy centers are using very frequently, and that's called stereotactic EEG, which involves a slightly different surgical approach to implanting a very thin wire-like electrode through a stab incision in the skin. And this electrode that you see here, the stereotactic EEG electrode, is about 0.8 millimeters in diameter. So it's a very fine, minimally invasive way to perform intracranial EEG. So to show some pictures of open craniotomy, these are often big surgeries to implant these 8x8 grids, and oftentimes strip electrodes, which you can see here on the side. This is a more involved procedure, but is very good at identifying regions of a seizure focus in the cortex and seeing how that seizure spreads. This is a very large bilateral study. It's not that commonly performed, but you can see here how we close the skin after we place the electrodes, and then pass the wires through the skin. We then wrap this patient's head in a big head wrap. They usually go to the ICU for a day or two and then go to our epilepsy monitoring unit. This is how many electrodes can be placed. In this particular case, is a craniotomy on one side and strip electrodes on the contralateral side. And this is what this information is used for: is to co-register with the MRI and then tell us what electrodes are involved in the seizure focus. And we have very nice ways now to map how this activity then spreads throughout the rest of the brain. We can also use this type of study where we place a grid over the surface of the brain to map normal brain activity. So for example, this is on the left side, and we can use it to map language. The way we do that is we actually, in the epilepsy monitoring unit, while the patient is awake and conversing with us, we can stimulate various regions through usually bipolar electrodes and see if that affects language function, if that causes anomia, or if there really is no functional change. That can really help us to localize. You can see here, Broca's area is localized and Wernicke's area is nicely localized. We can also localize the motor strip very nicely with these types of electrodes. This can be done awake in the operating room as well, but it's a much more convenient and comfortable situation, certainly for the patient, when we can do this in an epilepsy setting in the epilepsy monitoring unit. And so this really can also be done with stereotactic EEG electrodes, but it's a really nice function of grid electrodes where it's much easier to do and more consistent. So now we can talk about stereotactic EEG. This is in our center, the preferential way to perform intracranial EEG. We still perform craniotomies for grids when we really suspect a neocortical region of seizures, or if we really want to map an area well. However, for the majority of patients now, we can perform a very nice and adequate study with this much less invasive approach that doesn't require a large craniotomy, but in fact we can do by with a small stab incision, a small twist drill, craniotomy, and placing this very thin electrode into target locations that we've previously identified. This is what a big study would look like. Oftentimes we're placing anywhere between 7 to 17, roughly, stereotactic EEG electrodes, and each study is tailored to that individual's brain and to that individual's preoperative workup. We get excellent coverage into deep lesions. It's a very well tolerated procedure overall. And of course, just like with any stereotactic procedure, there are risks, for example, like hemorrhage. This is my planning workstation for stereotactic EEG. This is the BrainLab system. And so you can see we co-register the patient's MRI and plan here a trajectory into the mesial temporal structures through the cortex, and usually avoid sulci to avoid risk of hemorrhage. I like showing this picture because it's hard to imagine that these patients, with a big head wrap, after they recover from the surgical procedure, which usually takes a day or two, they go to the epilepsy monitoring unit, and then they really just hang out for probably roughly 7 to 10 days on average, while we monitor for seizure activity. During this time, they're just doing normal functions. We often have a stationary bike in their room so they can have some exercise because they're tethered with this cord. They're eating, have visitors during non-COVID times. And actually, importantly, they're very active participants in research studies, if there are research studies going on at the time. This is what it looks like in the operating room. And one of the nicest things about this procedure is that we can do a minimal shave. And after these electrodes come out, it's really only one stitch at each location. And here, not even a stitch, just Dermabond. And these heal very nicely. Just a little side note about the potential for research. This is a really unique opportunity when we have electrodes implanted in the brain for the purpose of mapping and localizing seizure activity. A lot of centers have capitalized on this opportunity in order to understand more about both basic neurophysiological functions of the human brain and also to understand more about epilepsy itself. The way that this has been done is by hijacking the clinical electrodes that we're already implanting and doing things like, for example, placing micro wires through the tip to record single cell activity at the target. This is the Benke-Fried electrode concept here. And so you can see how this is structured, and it's a really unique way to be able to get this kind of level of activity from the brain. This is a picture of the neurogrid, and is just an example of many of the sort of smaller footprint and non-invasive ways to get single unit recordings over the cortical surface. The idea here is that this type of material can be embedded within the plastic sheath of an 8x8 grid, where currently just wires run through. So really interesting ways to potentially utilize that the implant that's already going to be placed into a patient to get much deeper understanding of brain function. Again, with of course an IRB. This isn't done yet, to my understanding, but many centers are discussing how to embed this within their clinical system. And this is just an example. My mentor at Yale places in some patients a microdialysis catheter through a depth electrode to be able to perform microdialysis analysis on these patients, and it has found really interesting things about metabolism in epilepsy. So a very unique opportunity for those people who are interested in the clinical research aspect of epilepsy surgery. Okay, so in my remaining time, I want to spend a little bit of time talking about the various surgical approaches that we use for temporal lobe epilepsy. I've outlined them here again, and we can really see the distinction between palliative procedures, which again are aimed at reducing the severity or frequency of seizures, and definitive procedures where we're really trying to provide a cure. But if we don't achieve that goal, we again, nonetheless, usually derive a worthwhile benefit. So I'll start by talking about vagal nerve stimulation very briefly. You may have heard of this. This is an outpatient procedure. Usually takes about 2 hours to perform. We make 2 incisions, one in the neck, incision kind of similar to an ACDF incision, a little bit more smaller and more lateral, as well as an incision for the generator that's usually infraclavicular. We identify the vagus nerve, we wrap several coils around it, and then attach it to the generator. And something like 30 to 40% of patients, maybe even up to 50% of patients, achieve greater than 50% reduction in seizure frequency. When you look at the outcome kind of time plots, this does tend to improve with time. We're not sure why. And it's a generally very well tolerated procedure, and serious adverse events are rare. So it can be very nice to utilize on patients. It's variable in how neurologists and neurosurgeons utilize this therapy. Some will consider doing vagal nerve stimulation even before considering a further surgical workup, either based on their own preference or the patient's preference, whereas some really reserve vagal nerve stimulation for those patients who undergo a surgical workup but don't have more definitive options, but it is always an option. I'll move on now to sort of the more definitive realm. So this is, again, really has been the workhorse of epilepsy surgery, which is just the surgical resection of the seizure focus. And in this case, the seizure focus is thought to be the temporal lobe, specifically usually the mesial temporal lobe. And this procedure has had many, many variations that have different names, which I'll go into in a little bit, but essentially, traditionally, we won't go more than 4 centimeters posterior in the dominant hemisphere, which is usually the left side in the majority of patients. And that's, of course, to avoid any sort of dysfunction in language. And we can go more. Most people kind of quote a number of 5, but could be even as much as 6 or 6.5 centimeters in the non-dominant hemisphere. If we go more posterior in the non-dominant hemisphere, we worry about damaging visual tracts. Here you can see that with this resection, we can nicely have access to the amygdala and the hippocampus. There are many ways to perform what's now been called a selective amygdalohippocamectomy. This is a procedure where typically you remove less neocortex and really just focus your surgical approach towards trying to remove those mesial temporal structures, which of course are the amygdala, the hippocampus, and parts of the parahippocampal gyrus and entorhinal cortex. So various approaches have been described by Dennis Spencer, by Yasser Gill, and others, including the transsylvian approach, going through the sylvian fissure to access those structures, which has pros and cons, transcortical approach, and then even a subtemporal approach to just bypass the temporal neocortex and just access the mesial temporal lobe. I'll say now that the advent of laser ablation, in my opinion, has sort of obviated the need for some of these approaches, because now we can very precisely target just the mesial temporal lobe, although other people have different ideas about that, of course. So moving on, I'll talk about some relatively recent advances in surgical approaches for temporal lobe epilepsy, including deep brain stimulation and responsive neurostimulation. Deep brain stimulation actually was relatively recently received FDA approval for epilepsy, as you all may know, because we use it very often for movement disorders. It consists of placing, in this case, bilateral electrodes into a structure called the anterior nucleus of the thalamus. These electrodes are fairly small. They're 1.2 millimeters in diameter, the same as the electrodes that we use for movement disorders. And again, connecting them to a pulse generator, which is infraclavicular. And so here you can just see kind of a basic diagram of deep brain stimulation. Our target is the anterior nucleus of the thalamus. This is a part of the thalamus that is proposed to be connected with just general this circuit of papes and the mesial temporal limbic system in general, although it is used for also non-limbic system related seizures, just has really been a general sort of target for refractory epilepsy. So these are patients who have focal onset seizures, although it actually also has been used for generalized seizures. And of course, have been diagnosed with having medically refractory epilepsy, meaning they're drug resistant. There is a nice trial with 7 years of follow-up, actually even more at this point. And so immediately after 3 months, they saw that the number of seizures in the control group with the stimulation on went down by 40% compared to 15% in the placebo group. And this was, of course, blinded. So it was a pretty impressive early result. And interestingly, the results improved as far as percent seizure reduction every year. So at 7 years, people receiving DBS has seizures decreased by as much as 70%. And they also recorded quality of life improvements. Now I'll talk briefly about the RNS system, which is really a really interesting technology that we have for the treatment of epilepsy, which involves closed loop communication. This has a very specific indication. So RNS typically is a really great tool for patients who have a seizure focus that's been identified but cannot be treated. So reasons why it might not be able to be treated through a more definitive means like a resection or ablation are, for example, if a patient has, for example, bilateral mesial temporal lobe epilepsy, we know it's not safe to resect or to intervene in both the right and left mesial temporal lobe. That would lead to a lot of untoward consequences that are not possible. And so that's a great patient for something like RNS, where we can, rather than resect those regions of brain, place electrodes into those structures. Patients who have seizures that are, for example, localized to eloquent cortex, like, for example, localized to the motor cortex, those are not patients that we would want to consider resecting, because then they would have severe side effects. And so RNS is, again, an excellent way to be able to modulate activity in that part of the brain without inducing side effects. So we talked about patients must meet the definition of drug resistance, and patients who are at risk for neurological or cognitive deficits with resection. So how does this system work? It is really a really cool piece of technology. It is constant. After we implant it, it's constantly on, is continuously monitoring brain activity. It then detects patient-specific patterns that we program, and then it stimulates to essentially act like a defibrillator of the seizure, just like a cardiac defibrillator might act to change electrical activity in the heart. So constantly monitoring, detecting, and stimulating. In the meantime, it also records long-term data to really help further even localize these patients' focus. This is a kind of an example of how we can program this to stimulate at the onset of a seizure. And in this case, it's helpful to see a video of this technology because it really kind of helps to understand how this is functioning. So NeuroPace happens to be the only company that makes this particular device, which has been FDA approved now since 2013. So we implant the neurostimulator here underneath the scalp, and we implant electrodes into the region of the seizure focus. The stimulator is actually embedded within the skull. So it's nice that nothing is visible from the outside. So the way that it works is, again, continuously monitoring activity, detecting activity, and then responding in real time. And it's important that this actually occurs under the radar. The patient doesn't feel anything, including these small bursts of stimulation. So constantly monitoring activity under the radar, detecting a possible seizure, and then stimulating in order to stop that seizure before it spreads. Similar actually to what we saw with DBS, this is a palliative procedure. So it does not, it's not expected to provide a surgical cure for the epilepsy, but it is expected to decrease the frequency and severity of seizures by as much as 66% at 6 years, and actually 7 and 8 year data looks even better. And then most importantly, as we discussed, our surgeries are aimed at improving quality of life. And so we see that in this data from quality of life improvements. after being treated. So the last procedure I'll talk about is MR-guided laser ablation. This is really, I think, has been a game changer in the field of epilepsy surgery. It now provides us with a very minimally invasive way to definitively treat an identified epileptic focus that can be treated. And luckily, mesial temporal lobe epilepsy, specifically non-dominant mesial temporal lobe epilepsy, is very amenable to this kind of treatment. The reason this technology now exists is because is really actually not because of the laser itself. That hasn't been the advance. The advance has been actually new sequences within MRIs, so MR thermography, which allows us to see relative temperature changes in the brain in real time in response to this laser energy, so that we know exactly what we're ablating with great spatial precision. This procedure is performed with a patient asleep inside of an MRI scanner. And at our institution, we're lucky enough to have an MRI scanner inside of our operating rooms. And so we're able to really perform this in a great setting. And so here, this is a kind of a nice sketch of what happens. So the patient is inside the MRI. Previously, they have been stereotactically implanted with the laser, which is then attached. And we can sit in a control room outside of the MRI and essentially monitor what's happening within the brain by seeing these real-time temperature changes as they happen. Here's kind of a schematic of the actual laser, in this case going into what appears to be a lesion. In our case would be into the mesial temporal lobe, and we can withdraw the laser along a specified tract and really be able to control the region of tissue that we're ablating. With outcomes that are not quite as good, but very similar to temporal lobectomy. So I won't go through this for the sake of time, but in general, you know, in our talk, we can focus on this sort of pathway here. When we have non-dominant temporal lobe epilepsy, we really consider things like temporal lobectomy and MR laser ablation. When we have dominant temporal lobe epilepsy, we have to think, is it safe to actually offer a temporal lobectomy or laser ablation? And there are many ways, many tests we do to consider whether or not, you know, we think that there is going to be a dysfunction or side effects from a procedure. One of those is trying to understand whether or not they currently have preserved verbal memory or altered verbal memory. And if we think that we will produce side effects by providing by considering a temporal lobectomy or laser ablation, we'll consider things like responsive neurostimulation, vagal nerve stimulation, or DBS.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.